A very good afternoon, everyone. Thank you for joining us today. So today we're come together to go through what we've been doing in the last few months in the Health and Care Across the Life Course quarterly theme. In the Life Course, Health and Care Across the Life Course. I'm sorry, I'm just reading off the screen. So we're just waiting for Mark Gabay, our theme lead, but I thought we'll just start anyway. Today, we're going to be going through our updates, what we've been doing in the last few months and how we've been performing. Then our member co-lead, Joe Blair, will be talking through a potential application that they're putting through, or they have put through, on pediatric health inequalities. Dorcas is going to be taking us through the co-lead public advisor and professional progress and plans. We'll be discussing our research development networks. We'll then be moving into breakout rooms where we will be discussing about adolescents and cross-generational sub-themes in particular, and maybe try and discuss what projects that can come out of that. And then we'll come back together in this main room to discuss basically what was talked about in the breakout rooms, basically feedback, and then we'll close the meeting. Okay, so you may have all seen this screen before. Basically, it just tells you who we are. We've got Mark Gabay as our theme lead, myself, Pallavi Deshpande, as a theme manager, Clarissa as a theme fellow, research fellow, Dorcas and Paul are our public advisors, and we have Joe Blair, like I mentioned earlier, who's our member co-lead. We've got 6 sub-themes. We've got family and children, adolescents, working age adults, older adults, cross-generational and marginalized groups. We're always looking for projects to come to these themes. So if you have any ideas within any of these themes, please get in touch with us. You can always email me or get in touch with any of our team members just to talk about these particular projects you have in mind. We have several projects that have come to our theme ever since we started the ARC, and we've had about 106 projects that have come to the theme. It's quite a lot, I think, and about 76 we've applied for external funding, out of which 33 have been successfully funded. Out of those projects, about 10 have closed now. And just to mention, these projects are not only purely projects that we've applied for, they're also projects that have come to us for small, for support. They also include PhD projects, they also include internships, ideas, fellowships. So that's what the 106 really include. We have 9 PhD students with us and 8 interns. We've published quite a bit over the last several years, about 4 in 2019. I think those basically came maybe sort of a continuation of Clark projects. 23, 2020, in 2021 we did quite well. 39 papers were published, and we are sort of on the way to doing well again. We've got 4 since January, and I think that's great. We're just in February right now, so that's really good. And a lot of our papers have been cited as well, which is brilliant. Doing very well with the funding. We have presented some of this before, that pandemic-related funding, about £8 million. And recently we've got a few grants as well, bringing our non-pandemic funding to nearly £900,000. We've got about 36 member organizations that work closely with the HAECAL team. We're really proud of that. If you are a member, not really working with us yet, but would like to, please get in touch. We'd really like to work with you and develop more projects with you. So I'm going to stop sharing. I think we've got Mark here as well. So Mark, if you'd like to say a few words before we kick off.
Yeah, firstly to apologise, I had internet problems, but I'm back in now. So thanks very much, Pallavi, for stepping in and giving that summary. I think it shows steady progress. but we've already started from quite a high base, so we'll be discussing other work as we go on through today's meeting. And there'll be more about the sort of work we're doing at the ArcFest in March around the research development networks. So please do come along to that as well if you hadn't already got that in your diary on March the 8th. I'm now going to hand over to Dr. Joe Blair, who's going to talk about the work that we're doing in the children and families sub-theme, and specifically going to talk about inequalities in pediatrics. So that's the care of children. Thank you, Joe.
Joe, we can't hear you. I can't hear you.
Can you hear me now?
Yes.
Yeah, perfect. Thank you. So I was just thanking you for inviting me to share the very early ideas that we have for this project. We've applied for capacity building funding from the CRN, and the overall aim of this project is to try and achieve a better understanding of the barriers that children living with chronic diseases in deprived communities face in achieving good clinical outcomes. Okay, next slide, please. So this is just a summary of that statement. So the overarching aim is to grow a community of researchers which will comprise patients and families and professionals who live and or work in deprived communities in the North West Coast. And through delivering a project examining health inequalities in children living with chronic illness, really secure some depth and experience in an advisory group that will go forward and take this work further in future years and grant applications. Okay, next slide, please. So this work comes out of a number of workshops which were led jointly with Alder Hey and of course very importantly with Carrie Hunt from the Starting Well group of the Liverpool Health Partners, and we ran them over about 18 months, and they sort of ground to a halt a little bit during COVID, but there was a very strong focus on the impact of living in deprivation on health outcomes in children that attend Alder Hey. So it was quite Alder Hey centric, but that of course just reflects the fact that that's where we have our experience and our knowledge, and I'm sure many of the themes that we discussed would be pertinent to the care of children right across our patch. So out of those discussions came a group of paediatricians who were very interested in the impact of deprivation on the outcomes of children living with long-term illnesses in their own departments. And in particular, Caroline Jones, who's one of our nephrologists who was desperate to get some evidence to justify funding for social workers in the nephrology service, because many of their patients have extremely complex and demanding conditions, which place a terrific burden on families. And she was clearly observing the fact that patients that were living in the more deprived communities were coming into hospital and suffering quite significant adverse effects, particularly post-transplant. So she drove this project, but my colleague Rebecca Thursfield, who's a respiratory physician, was also very interested. And she has a strong interest in the treatment of children with cystic fibrosis, which again is a complex and very demanding condition to care for. And Atre Gatak, who is a diabetologist, and many people in the audience will be familiar with the complexities of treating diabetes. I'm an endocrinologist or a hormone specialist, and my discipline is possibly less affected by the impact of deprivation, but I certainly think it influences who comes to see us in the first place. And I mentioned, of course, Carrie Hunt, who drives a lot of the work that we do in this partnership. But we also linked up with Health Junction, and people on the call may be very familiar with this group. It's a not-for-profit organisation which has worked particularly in the adult community at looking at health inequalities and jointly developing interventions to address these and testing them. And they've got a strong track record, which you may already be familiar with. And then last of all, the Alder Hey charity has already committed a small amount of funding to develop some focus groups to start to explore some of the reasons for these health inequalities. And of course, if this work goes forward, we're extremely keen to partner with ARC and ARC partners across the patch. Okay, next slide, please, Pallavi. So I thought it'd be helpful just to focus on two of the conditions that we hope to look at. And I think we obviously have selected these conditions because it's what we've got personal experience of, but many of the barriers that children and families experience in caring for these complex and demanding conditions, we think will be generic across many different conditions, whether they're rare diseases seen somewhere like Alder Hey, or much more common paediatric diseases which are seen across paediatric departments and in general practice across the Northwest Coast and further afield. Okay, so the first condition we're going to look at is cystic fibrosis. And at the risk of teaching my granny to suck eggs, I thought it'd be helpful just to put up a couple of slides about the condition. This is an inherited condition which affects all demographic groups equally. You're no more likely to get cystic fibrosis whether you live in an affluent community or a deprived community. It's a genetic condition in which there's a change in a gene which encodes the cystic fibrosis transmembrane conductance regulator. And the impact of that is that there's an impact on the movement of fluid across cell membranes, and that affects two principal organ systems. In the airways, mucus accumulates and blocks the airways, and that results in recurrent infections, and the infections damage the lungs, results in fibrosis or thickening of the airways and a reduction in lung capacity. This can also have an impact on the heart as well. And in the gut and the digestive system, these thick secretions block the pancreatic duct and the bile ducts. And that means that the enzymes which are released from the pancreas into the digestive tract aren't released, so patients have malabsorption. And they need to take a medicine form of these enzymes in order to be able to absorb their food. And over time, this also results in diabetes as the pancreas is destroyed. And in time, the liver is also affected and patients develop cirrhosis. Okay, next slide, please. So cystic fibrosis is a condition, as we say, which affects all socioeconomic groups equally. There's a very active patient advocate group called the Cystic Fibrosis Trust, which collects data and has a very robust registry which is used for research purposes. And they estimate that approximately 11,000 people in the United Kingdom are living with cystic fibrosis. The median age is currently 21 years, and there's recently been very significant advances in the treatment of cystic fibrosis, which means that life expectancy is now thought to be approximately 50 years. But patients that were diagnosed 30 years ago have a reduced life expectancy, and in 2020 about 100 people with cystic fibrosis died, and the median age at death was about 36. Okay, next slide please, Pallavi. So what do we know already about the impact of deprivation and clinical outcomes in cystic fibrosis? Well, a lot of this work is has been led by David Taylor Robinson, who of course is extremely well known to everybody on the call. And a number of years ago, he led a UK cystic fibrosis registry study, which examined clinical outcomes in association with deprivation. They included patients that were less than 40 years old at last follow-up and had more than one clinical outcome and a valid postcode from which they could derive an estimate of deprivation. And this is a historical study now. The last point at data entry was in 2009. And as I'll show you later on, there's been significant changes in practice. So some of these data need to be interpreted with that in mind. So data were available from just over 8,000 patients, and over half of these were male. And in total number of observations gave approximately 48,000 patient years worth of data. Next slide, please, Pallavi. So looking at a number of outcomes, you'll see three graphs on this slide. Patients living in the least deprived quintile are shown in the turquoisey colour, and those in the most deprived quintile in red. And what you'll see is that patients that were living in the most deprived quintile were lighter, they were shorter, and therefore their body mass index was also lower. And this is very important in cystic fibrosis because your clinical outcomes are strongly related to your state of nutrition. So not only does this show us that maybe the diet that these children had access to was less adequate, it also has a significant impact on their overall prognosis and lung function. Next slide, please. Now, some of that may be a cystic fibrosis related factor. It may be that they have less access to treatment, they have less access to, or they're less consistent with their dietary supplements and the enzymes that they have to take in order to enable them to absorb food properly. But we're also aware that children that live in highly deprived areas are shorter. And this slide here shows the number of children with short stature according to their deprivation quintile. So children shown in the yellow dots are those living in the most affluent communities, and those in dark green dots are living in the most deprived communities. And all this shows is that children living in the most deprived communities are likely to have a height which is significantly below what we consider to be the normal range, although there has been some significant improvement in those growth parameters over the last 10 years or so. So this suggests that there's possibly a combined effect, both the impact of disease management and cystic fibrosis, but also an inherent factor about the environment in which these children are living. Okay, next slide, please. And we all talk a lot at the moment about the impact of deprivation on obesity, but it's also important to appreciate that if you're living in a deprived community, you're also more likely to be thin. And if you live in the bottom quintile in terms of deprivation, you're about twice as likely to be considered to be clinically thin than those living in the most affluent communities. So just some evidence there about the background communities and how these possibly also impact or have an additive effect on the outcome of children with cystic fibrosis. Okay, next slide, please. So turning now back to the study, this looks at lung function, and the slide on the left, entitled FEF1, reports the data from a test that we do to assess the health of the lungs. And what you'll see is that over the time course of a child's life, there is a shift towards sort of fairly equitable lung function in adolescence and early adult life, but then a separation again. And when we look at the likelihood of developing a chest infection with a germ called Pseudomonas aeruginosa, which has a significant impact on lung function, you see that throughout the lifetime, children living in the most and adults living in the most deprived quintiles are more likely to have this infection than people living in the more affluent backgrounds. Okay, next slide, please. Now, looking at how these infections are managed, you can see that children that live in the most deprived quintile are more likely to receive antibiotic therapy, and that's possibly one reason why there's less disparity in terms of lung function. And you'll also see that they're more likely to receive that as an inpatient than they are at home. And this probably has quite a significant impact. Attending hospital is a costly event, and we estimate for a family attending Alder Hey for an outpatient appointment, the cost is approximately £30. By the time you look at travel and parking and refreshments and so forth, the estimated cost is approximately £30. So if you have a child in hospital for 14 days or so having intravenous antibiotics, there are obviously impacts in terms of schooling for the child, possibly lost work for the parent and income, but also additional costs of parents having to eat at hospital, gifts that are given to the child to keep them going and so forth. So although it's very good that children are supported in this way, we also shouldn't overlook the fact that that treatment in itself is an additional burden to the family. Okay, next slide, please, Pallavi. Looking at supportive therapies, children living in the most deprived quintiles were less likely to receive this therapy called DNase, which reduces the thickness or the viscosity of the lung secretion, and therefore gives some degree of protection against lung infection and lung damage. It's quite important to note that since this study was undertaken, there's been a significant increase in a number of people that receive this therapy, and it'd be interesting to see whether that inequality has reduced at all. You'll see the same picture for people being treated with inhaled antibiotics, which is contrary to what you would expect, given that patients are more likely to experience infection. And you'll see that children with living in deprived quintiles are more likely to receive supplemental feeding, demonstrating that people are aware of the risk of undernutrition and trying to do something about it. But again, this places an added burden and an added treatment on the family of these children. Next slide, please, Pallavi. As I said, this is a fairly old study now. Data collection was included patients up to 2009, and there's been a very rapid rate of acceleration in new discoveries and implementation into clinical practice. So now we see that many patients are receiving what we call CFTR modifiers, and these are medications which actually correct the abnormality of that membrane receptor that results in the thickened secretions which manifest as repeated lung infections and malabsorption, etc. And really there's been an explosion in these therapies, and it's a very exciting time for people working cystic fibrosis medicines, that they're able to offer medications which are life transforming. But I think it's going to be a very important question for us to ask as a community about how are patients, how equitable is access to these therapies, and our children living in deprived communities, which are at greatest risk of having the adverse outcomes, do they have equal and equitable access to these expensive interventions? Next slide, please. So who would also just touch on childhood diabetes, because this is also a disease where there's a very robust national registry which gives us very solid data describing the impact of deprivation. Next slide, please. So I'm sure everybody knows what diabetes is. It's a condition in childhood. It's usually type 1 diabetes, which results from loss of pancreatic function and therefore loss of insulin secretion. And insulin has the effect of opening the receptors on cell membranes which allow glucose to enter cells. And if you have diabetes, you've got loss of insulin. So glucose can't enter cells, so you can't use it as an energy source, but also the accumulation of glucose or sugar within the bloodstream has a number of different damaging effects on blood vessels and other organs. Next slide, please. So if you have poorly controlled diabetes, that's diabetes in which your blood sugar levels are high, you're much more likely to develop complications. And those are typically relate to damage to your eyes, retinopathy, damage to your kidneys or nephropathy, or damage to the nerves, which is nephropathy. You're also more likely to have disease affecting your blood vessels, which may manifest as stroke in the brain, as heart attacks in the heart, and also poor circulation. So you may have heard of people that have amputations because circulation to the limbs is reduced. So I mentioned that the risk of developing these complications is related to your control, how your blood sugar levels are maintained within the circulation. And we can measure that on a blood test called an HbA1c test, which determines how much sugar is stuck onto red blood cells. And that gives us an understanding of the average blood sugar levels over the previous 3 months. And this is used as one of our key indicators of the quality of care and predictors of long-term health outcomes. Okay, next slide, please. So looking now at the national report from 2019 to 2020. Next slide, please. We can see that there are very striking differences in the HbA1c, or the marker of the quality of diabetes care, according to the degree of deprivation that the child is living in. And again, this has been an exciting period for people that work in childhood diabetes, because there have been many significant advances made, partly due to just investment in resources, so more doctors, more nurses, more psychologists, etc. And that's resulted in a very healthy and sustained reduction in HbA1c over the last 6 years or so, 8 years or so. And all areas of community have benefited from that investment. But you'll see that despite that investment, the inequality between groups persists. And even in this report, we see that people living in the most deprived communities have significantly poorer outcomes in terms of HbA1c than those living in more affluent areas. Next slide, please. And the same is true when we look at race. There's less marked discrepancies, but you'll see that patients that are of Black ethnicity have significantly poorer HbA1c or blood glucose control than those from other ethnic groups, and therefore have a much higher risk of developing the complications we mentioned before. Next slide, please. No, these slides, I think, are some of the most interesting but also concerning, because they look at the access that patients have to diabetes technologies. And diabetes technologies have been accredited with much of the improvement in glycemic control. And I still think the jury's out about whether or not that's true. But if you believe that, it's very concerning that there are such differences in patients' abilities to access this therapy. So in the light blue bars, you'll see how many patients had access to insulin pump therapy according to their ethnicity. And you'll see that about 40% of children with type 1 diabetes who were white had access to therapy with an insulin pump. And that was only about 27% if you were black. And there was a graded percentage between different ethnicities. And then when you look at deprivation, you'll see a similar pattern. So if you live in the most deprived portions of our society, you are less likely to have access to an insulin pump. And there's a dose-dependent effect until you come to the least deprived parts of our community, where you are approximately 30% more likely to have access to this therapy. Okay, next slide, please. And we started to explore this in a randomized controlled trial that we undertook a number of years ago. It took a long time to deliver and quite a long time to publish, so the data were only published in 2019. But this study was driven by a frustration that there was a widely held view that insulin pump therapy was significantly better, without accounting for the fact that the people that got insulin pump therapy were highly selected and in itself were more likely to do better. So there was definitely a culture about 10 years ago that if you could only be eligible for this therapy if you had parents who could do blood glucose tests very regularly, who could adequately calculate the amount of carbohydrate in your food, etc. So only people living in the most privileged parts of our community were getting access to this therapy. And what we did in this randomized control study was just, as we say, just blindly randomized patients that were newly diagnosed. And that meant that patients from deprived communities had exactly the same opportunity of having insulin pump therapy as those from the most affluent communities. And the study wasn't powered to address the impact of deprivation, but what it did show very nicely was that you could start patients from the most deprived communities on insulin pump therapy at diagnosis, and they coped, and they weren't more likely to get any adverse effects from those families that were living in more affluent areas. And in fact, I remember talking to one of our diabetes nurse specialists who had started a child off on insulin pump therapy that she said she would never have dreamed of treating, who actually did very well. And I think that was quite a sort of salutary tale to many of us. And I think it's really important that we question healthcare bias when we think about health inequalities in healthcare. Okay, next slide, please. So looking at the use of continuous glucose monitors. So these are devices which tell a patient continuously what their blood sugar level is and helps inform the management in terms of when to eat and when to give insulin and how much to give. And again, you see this very similar pattern. People that are white are more likely to have this technology, and people that are least deprived are likely to have this technology. And there's a degree of disadvantage related to ethnicity and deprivation. And there is more convincing data, I think, that this technology does impact glycemic control, and therefore not having access to it is likely to influence your long-term prognosis and outcomes. Next slide, please. And then, of course, we're seeing much more type 2 diabetes. When I started work, type 2 diabetes in children didn't exist, and now there's nearly 1,000 children with type 2 diabetes in England and the UK. And what you see here is that almost 3/4 of them live in the 2 most deprived quintiles in the country, and about 2/3 of them come from ethnic minority backgrounds. Okay, next slide, please. So returning to our project, so we're going to use these 2 conditions as chronic diseases within which we can start to explore where the barriers lie to children and families achieving good clinical outcomes for their children. Next slide, please. So our first objective is to recruit children living with chronic diseases and their families living in deprived communities, together with healthcare professionals working with children with chronic illness. And we're going to do some focus groups, which we hope will have a very open conversation to try and understand where the barriers lie in achieving good clinical outcomes, both in terms of factors which relate to communities, factors which relate to families, and factors which relate to healthcare delivery. And hopefully learn from each other and try and address some of the biases which we think exist. Okay, next slide, please. And from those focus groups and then from the wider community as well, we hope to develop a team of investigators which will comprise professionals and children and families to design some interventions to try and address those factors. And then finally, to design a study protocol in which those interventions can be tested. Okay, next slide, please. As I mentioned before, we're going to be working with a group called Health Junction, and they've been a partner with us along the way to help us understand how you can start to understand barriers and also things that facilitate good outcomes, and then how you can work with communities and with patients to design interventions. And the two co-founders have kindly agreed to support the focus groups. That's John Smith and Kath Aitken. Okay, next slide, please. So the focus groups will comprise 20 families and 10 healthcare professionals. And as I said, we plan to explore some clinical outcomes, and I've listed some here. So nutrition, prescriptions is a real challenge. Often these are given for only a month at a time, and families inevitably miss days when they run out of prescriptions and they can't collect them. Access to medical care and what we call patchwork families, so children that have maybe separated parents or moved into grandparents' homes at different times of the week. Also, how well are we supporting families to understand their condition and their management, and how autonomous are they in that management? And then thinking again about literacy and languages, and also very important bias within healthcare services. Okay, next slide, please. And as I said, we're going to recruit a group of investigators. Sorry, this is a bit of duplication, to design interventions and test them, and then take a study protocol forward for competitive funding. Okay, thank you. Next slide, please. So the impact of this study, we hope that as a group we will develop a better understanding of factors which are protective, but also barriers to achieving good clinical outcomes, and co-design interventions, and then to design protocols to test them. And really, we just think that this is going to be a vehicle which is going to help us to develop a group of patients and professionals who are going to go forward and start to drive a research programme in terms of health inequalities in chronic childhood illness. Okay, thank you very much. I think that's my last slide.
Because as far as I know, that other consultants, they talk with your consultants.
I need to unmute. Hi, thanks. That's great. That's really interesting. So any questions in a couple of minutes to Joe about that? I think some fairly shocking statistics, and there's clearly a relationship between deprivation and ethnicity. I would suspect they're not independent factors. But clearly a lot of a big challenge there for researchers and for the ARC. And I just wanted to see what colleagues felt about this, and how well, I guess it's also a question of putting your hand up, not literally, but literally if you want, either to ask a question or comment, or to judge the enthusiasm for taking this forward as a project development opportunity between us. Graham's asked what co-production methodology will the study use. What were you thinking of, Graham? Because I guess we do have inbuilt systems starting with a HIAT for how we begin to initiate these conversations with members of the public, and we through the infrastructure of the ARC, the intention is that we pull together a group of collaborators from professional and public advisor backgrounds with academics to do that co-production. And they would indicate other organisations that we would also need to be involving to get that full engagement, such as charities, etc. Were you thinking of something else as well?
Yeah, I was thinking of using things like participatory action research as a robust approach, because one of the criticisms of co-production is that representatives don't always represent the key issues, the real world of the individuals living with a condition, for example. So I was just interested really, because it's certainly a challenging area, isn't it, from that perspective, how you capture the voice of young people as well, not just carers and parents.
Well, we have our Seldom Heard Voices forum, which we could use for that as well. I think it's an interesting idea to what extent we invest in the research into research as a way as well. I think there is good evidence that Clarks and now ARCs do co-produce quite effectively from independent evaluations, including our own. But that's, well, good points, Graham, and we can pick up certainly areas from that to build in to our approaches and to sort of double check.
And you know, I have to put our hands up. I think what we're bringing is a group of clinicians that have got a lot of experience in the management and of these conditions and observing the impact of health inequalities. But we would certainly have to partner with people who are expert in the methodologies. We as a group, we don't have those, but that's, you know, hopefully that's what this partnership is about, isn't it? Showing those expertise.
Yeah. And my question to you in response to you, Jo, would be to go to the national theme, child theme, which I think we need to double check. I think it's led by PENARC, the Child Research into Children's Health as the national theme, and see what they're doing in this space and what they're already doing about health inequalities and chronic conditions, and see what the space would be for either collaborating with other ARCs or picking up an existing approach and adapting it rather than starting from scratch. Because a lot of that prep work that Graham was referring to may already have been done. I know that Stuart Logan has a big interest, for example, in learning difficulties and inequalities, as does Umesh Chauhan in Preston, for example. Any other comments before we move on? Could I just get a sort of a show of hands, either electronically or put your camera on and put your hand in the air, to get a sense of whether you think this is something we should be taking further, at least through to a formal development that we can then take to the fest meeting. Just waiting to see if we get a majority or not. Looks like we're heading that way. So I would have my hand up. 1, 2, 3, 4, 5, 6, 7. Yeah, the hands go down again. The thumbs up, unfortunately. But yes, I think that's a good indication. Pallavi, would you agree?
Yes.
Okay, yeah. So we can then take this forward with Jo in the sub-theme and start to build this into a bigger critical mass. And Jo, you might want to use your links you've already got with other providers and get them on board. I think that's key to try and get a provider buy-in. And then we can work with our Seldom Heard Voices and also potentially primary care. Are you fairly confident that the two indicator conditions would be cystic fibrosis and diabetes, type 1 type 1 and type 2, in fact?
I think so. As I say, there's lots of background data that we can draw on in terms of understanding where the health inequalities lie. My colleagues in nephrology are also very keen to be involved. They've got particular concerns, and rheumatology, and of course obesity is another area. So we've been speaking with our colleagues in obesity and took some a suggested project to the Lawn Group last week.
Yeah, so the question is, what would the project look like? Would this be a project onto how do we build some sort of structures that proactively looks at equity in the provision of care and the offer of types of care and proactively target groups? Or is it about data recording, or are we going to look and then do some exemplar areas? Or I guess that's the next stage, to think through what would it look like as a project. Absolutely. And what's already going on. It may Absolutely. Just be a flag that always goes up. Have you checked? This is like somebody who's likely to not be offered this. Have you proactively discussed it?
Mm-hmm.
So I think maybe we should move on to Dorcas, now going to talk to us about the public advisors and professional leads and progress and plans. As you know, In the ARC Northwest Coast, we have co-leads alongside the academics who are the formal NIHR leads for each theme. We have equal status for our co-leads who are public advisors, who you've met already, Paul and Dorcas, and our professional co-lead who you've just been hearing from, which is Joe Blair.
Thank you so much, Mark, for giving us the opportunity to bring our partners up to date again. I'm Dorcas, as you've seen from Pallavi's first slide, and Paul is going to is here as well with me, and Joe has just spoken to you. Next slide, please. This is a new concept about a year ago in which they asked us to apply for co-leads, and I think it's a good way of us being involved with the researchers and with the teams. The ACA team, they've welcomed us from the beginning, really, and we've had a good support from Pallavi. And we used to meet fortnightly to discuss issues that we were worried about. And I think that's embedded us into the system as well, into the team, because we were a bit apprehensive about how we're going to cope. And then to even do video, really, we were supported about that. And we've been able to do presentation and Zoom videos at ACFest, and that has really empowered us as well. And we look at the monthly projects and we look at the reports to see, you know, where are the partners who are doing this, and again, what are the PAs that are attached to the research, because we first want to know if our PAs are being used effectively. And it's an opportunity to discuss these reports and when we make the manager. Next slide, please. What I find with this really is the empowerment, really, because my background is as a midwife. I've done research before, but it's a long time, and I'm retired. So being able to do my own presentations, I'm getting better at it, and it's really good. And for us to be able to raise points, I feel they do listen to us, and that's what Mark is saying. We're equal partner. So when we are treated the same, they will ask of our view and they take that forward. And we bring value as members of a team. It's very, very important. And I'm sure it's the same in other teams as well, because in fact, we are being valued and we are encouraged to develop ideas on research ideas. At the moment, I've been looking into domestic violence, maybe a Merseyside, or now we're looking at prioritization project in which we look at how many priorities have we got within domestic violence, and just pick one or two to do research on it. And Paul is quite really active with the younger ones and the youth in his area, and he's been doing boxing with them, and he's very, very, very passionate about mental health in the younger people. Next slide, please. The discussion around PAs attached project is about when you have a project as partners or research, and you've got a PA with you, we want to make sure you are using them. And we want to make sure that the monthly team meeting, we are involved in it, even within the agenda, we are allowed to put agenda on. We want to be able to be part of the project and be part of the principal investigator as much as we can. And even to the extent we were able to be part of the interview process and selection for our co-lead job for the partners. The annual report does highlight the work of the team, and that's very important for us to look at it. I think our role really has evolved than when we started. I was telling Pallavi, I'm quite busy at the moment because we are working in collaboration and working together, and we look at the research, and you know, if there is any issue, I can always ask Pallavi, what do you think we should do? What should I do? And to have somebody to back us up like a mentor as well, that's what Pallavi is there for us. We can always talk to Clarissa, or we can always talk to Mark, but Pallavi is the one that supports us. Next slide, please. And I think that's it really. It's just a snapshot of what we do, and it's a snapshot of how we work and how we work in collaboration with our team members and how we are valued. Thank you so much. I only had 4 minutes.
Yes, thank you very much. We're going to go into breakout rooms very shortly, but just to confirm that the importance of the co-leads in the theme is cannot be understated, really. And for those who find perhaps talking to me or too daunting, please do feel free to talk to Dorcas or Paul if you want to try out an idea and see how best to share it with the wider group. So can we now, I think we're now going to move into breakout rooms, is that right?
Mark, do you just want to have a few words about the research development networks?
Yes, so I'm starting. Oh yes, of course, that's me, isn't it? Sorry, I should look at my own agenda, shouldn't I? Too many screens. So the research development networks are hosted by different themes. They're cross-theme by definition. And at the moment, we're hosting 3. Social prescribing network, where social prescribing is increasingly discussed in reorganizing healthcare. It's an alternative to medicine, as in pills or creams or whatever. And the idea is, or formal therapies, the idea is it's around lifestyle or community activities or a range of other things that allow people to manage their healthcare and recover from ill health in different ways and to prevent ill health. There are now lots of social prescribing offers, particularly through primary care, and this network is meeting on a regular basis, looking at what research has already been undertaken. It's one of our prioritized themes within this network, and what's being developed both within our ARC and elsewhere. And please do visit the website, and the dates of when those meetings are on there. The social and community, and I chair that one, the social and community at the moment at least, and community mental health and well-being research development network is chaired by Rhiannon Corcoran. And this is looking at ways that we can have interventions, for want of a better word, activities at a community level that are there to support social and mental health and well-being. So how do we work as communities, as neighbours, to work to activate those strengths in communities and increase those strengths in communities to care for each other, to support each other, to do activities together to support our mental health and well-being and look after each other's mental health and help us recover if we've had mental health challenges. That grew out of the Seaside and Towns Research Development Network, and it was such a large topic that it was sensible to split it off as something independent. And then there's the Seaside and Towns, Seaside Towns and Communities is the word missing off there in the Northwest Coast. So there's a national emphasis led by Chris Whitty on poor health and high health inequalities in coastal areas compared to the rest of the country on the whole. It's not the only place, but there's certainly an association between coastal towns and communities and relative low employment levels, low assets, poverty, etc. So we've been looking at that within the Northwest Coast area and developing from that, we hope, some work to undertake research into that. So from that, a number of ideas grew initially, which is now focusing down really on 2 areas, as the mental health one has become independent. One of those is what's called beachside schools. So using the coast itself as an educational amenity for children, but also exploring how that could be done as an intergenerational activity so that you can get older adults to spend time with children, sharing that space and seeing how they can both use it for their mutual health and well-being using that beach school initiative. So lots of work happening there, and that links to the Eden project, which has now got planning, which is going to be an Eden project in Morecambe based on seashells. What they're now looking for is the funding. And I think they have some of that, but they are now fundraising. And there's quite a lot of work happening at University of Lancaster, some of which is linked into the ARC, some of which is separate, working with the Eden Project to see what research we can do alongside them and lots of the projects that will emerge from that. And that will inevitably link into the beach schools initiatives. Other initiatives are all up and down the coast about using the amenity of the coast for both leisure, but we're focusing on education and hopefully intergenerational education. The other thing we've been looking at is how we can apply the learning from the systems resilience work that was undertaken in Clark in the public health theme. And that has brought together ideas around what was discussed as high street regeneration, and also looking about how we can engage and empower people to work at a community level in real ways with local authorities and other statutory organizations that are making decisions about investments in their communities and in their towns and communities, and how we can get full empowerment for communities to be involved at the decision-making level when the decisions are being thought about, not when the decisions have been made and they're just checking that everybody's okay with that and they'll still vote for me having made that decision, which is what tends to happen now. So that to some extent links with the Marmot approach, but we're not only looking at the Marmot approach in the Marmot towns and cities. So that's where that's up to. We will be sending out information about when these meetings happen. The purpose of these meetings is to co-develop grant applications to bring investment in to be able to undertake at least one project. And the intention is that that's done within a year. I'm now going to shut up to allow us to get into breakout rooms. Would our two facilitators like to report back? Let's start with the group I wasn't in. So is that, who's feeding back from the...
Shall I feed back on that?
Of course, yes, please,
I don't think we didn't actually decide who's feeding back. We've had a really good discussion. Quite a lot of interest in taking this forward. Different comments made about the possibilities. What you were talking about, the Eden Project, that's obviously one huge possibility. I was talking about the fact that in our systematic review of a lot of the work that's been carried out has been looking at outcomes. Just if there's been sort of what I call intergenerational activities, the outcomes have been measured either for the children or for the older adults, and that we need to look at ways of comparing meaningful outcomes for both groups if we're going to take the research forward. And also there's very little research actually carried out in the UK in this area, so it could be an area that would be of value. And clearly it's also, I would imagine, of huge interest to several of the themes in the ARC as well. And I just said I've tried to contact Kate and waiting for her response. I think she would have quite a lot of comments, inputs, because she's led a beach school and a forest school, I think, hasn't she, in the past as well. So I think that I hope I'm summarising correctly, but there seemed to be a lot of interest in taking this forward, and a lot of ideas about potential projects as well. Thank you.
Okay, Paul.
Yeah, so thanks very much for your inspiration for both groups, really. Really appreciate it. Give me, again, a lot more ideas. I know there was a few people that have mentioned a few ongoing projects at the moment. Everybody seems to be supportive of looking towards something in this kind of adolescence area, and also kind of looking for different topics as well. One point that was really mentioned, I think Graham mentioned it, about not always looking at the negatives and looking at some of the positives out there as well. I think one of the groups mentioned social media and mentioned that that could be quite a negative for some children, but on the other hand, social media has been a lifesaver for some, and keeping that interaction between friends groups and and schooling across that pandemic. So it's kind of how can we take the lens from the negative and the positive. So plenty of things to think about. I'm definitely going to go away and kind of pin my ideas down now, and hopefully the next time we get together as a group, I will kind of have an idea to kind of put in front of you to see whether you're supportive or not. So yeah, thank you.
So Could I suggest that as a way forward, if people have any specific ideas or outline, send sort of mini paragraphs for a research idea, particularly if it's something that they've already been developing with somebody else or have done with somebody else or have some evaluation evidence on already, that they send that through to Pallavi and then we can collate it under those two subgroups. Could I just have a show of hands of how many people think that they might have something they want to do that with? So Carrie does. Anybody else? Because you said, Mari, there was a number of people suggested things. I thought they might be able to put, yeah, the green tick hand stays up. So if you could do that. Carol, you've got something. Carrie's got something. Anybody else? Oh, Mari, you're going to have to go and nobble those people offline who said that they had an idea and get them to write it down as a, even if it's just a handful of sentences.
I think some people's ideas were possibly sort of just thoughts that had sort of arisen today, so I can understand why perhaps people are
okay.
mulling them over.
If you look at the chat, just again, for anyone who didn't pick it up, there has been a big ARC linked report on child and adolescent mental health with the pandemic, which is in the chat, both under myself and Pallavi, so towards the bottom of the chat.
I think Simon has something to say.
Yeah. I wanted to say, Pallavi, when I was in Liverpool, the adolescents were coming to the mosque with the parents, and they were spending quite long time there, like for the Quran, learning many things. So that spaces are also can be used to toward the elder and the adolescents if we check these kind of things. Yeah,
I guess there are those spaces. So if you think about the Quran, the community research engagement networks that the Equitable Place-Based Health and Care theme in ARC looks after, they are increasingly relating through faith groups, charities and third sector organizations to link into the communities and using them as a means to do that. So picking up on that point, Simon, that is definitely a place, I think, where we could use the Corans to see what activities are already happening that's looking across interactions across different generations and across the life course in such ways. And I guess we've been focusing on adolescent mental health. There was an interesting recent paper that was written by colleagues in psychology in the University of Liverpool, actually said, although there was evidence of a deterioration in mental health from the published research, at least at the beginning of the pandemic, towards later on in the pandemic, it seemed to be dropping back toward normal expected levels, which isn't what people were thinking, but that's what the research is saying. So the research, of course, might be flawed, and we might want to say that that's because they haven't looked in the right places, or they've looked in more affluent areas. But it's certainly an interesting question that it is contentious the extent to which there is a long-lasting negative effect on mental health from the pandemic, or whether people, after the initial shock, their resilience came through, and in fact, for some people, it was quite supportive. Yeah, so I see Catherine's made a comment in the chat about that. So anything else anybody wants to discuss in general about today, or about the ARC before we close, or about this theme? Okay, well, I don't want to force it. So many thanks for your time and energy today. Can I just check by a show of hands, actually, while we're here? So the next ARC Fest, and can you use your green ticks, please, here? Or is there a red cross as well as a green tick? Does anybody know?
Yeah, I think if you want your hand to stay up, you have to put the green tick on.
There isn't a red cross that says the opposite, so no.
Let's have a look.
I think there's a red cross, yeah.
Yeah.
Oh,
yeah.
We've been talking to the member organisations about whether whether or not they wish. You can take your green crosses that we're not voting yet. Whether or not we should have a hybrid June ArcFest. We were going to hold off till September, but there seemed to be a reasonably a level of support in the employer organisations for having a hybrid June ArcFest. I think what we hear at least is that the Prime Minister is going to be announcing a removal of almost all of the public health restrictions in the coming days. So I just want to do a show of hands, green for yes and red for no, as to whether or not you were supportive of a hybrid ArcFest in June, which would be in Liverpool at the Corrie.
Florrie.
Florrie, did I say Corrie? That looks like an overwhelming support. There's a few neutrals. There's no red crosses. Staff can vote. It doesn't mean you have to come. It means it would be available to come if you wanted, and there'd be some help. We would be having hand washing and masks and some distancing, by the way. I was at the football last night and I had negative comments made about my mask. Had he repeated it, I'd have referred him to the number of papers I've written on the topic of the pandemic and suggested he put his brain in before he spoke. However, I was one of about 20,000 that was wearing, that's not quite true, but there were not many masks, I think, from society in this country at least. It seems to be a lost cause. Okay, so I think that's a very strong indication, and thank you for that. So I think we almost certainly will have a hybrid event in June, which means that there will be face-to-face activity, there'll be online activity. Breakout rooms will not be in the face-to-face space, they'll be to one side in a virtual space. So where we're having the sub-meetings, there will be a parallel face-to-face and online versions. We cannot have the online in the room at the same time as we can with the main sessions. And we'll see how that works. So please do come along on March the 8th, and we're going to be looking at our what we call connected research communities as our theme for the day, talking about all the different ways that we co-produce, Graham, and the way that we do that and how we bring different groups and different voices into the same place to co-produce our work and to come up with ideas. Thank you very much, everybody. Any other comments, final statements, anything I've forgotten, Pallavi?
No, I think you've covered everything.
And thank you very much to the facilitators today for your hard work and preparation. All the best, everybody. Keep well and see you in March.